Good morning, everyone. Good morning and welcome. Let me start out by thanking you all for being a part of the critical conversation that we're going to have today. And then let me also thank Harvard University's president, Larry Bacow, and University of Michigan president, Mark Schleschel, for convening our second joint summit on the opioid crisis. The people in this room today represent a multitude of disciplines, and come from an even greater number of different institutions. But we share an acute awareness in common, and that is the awareness of the opioid crisis, and that this crisis is one of the most urgent public health problems of our time. We're confronted with that reality on a daily basis in our academic research centers, in our schools, in our hospitals, in our clinics, and in our communities. Lastly, or lately, we've been thinking a lot about a book that I read this summer by Beth Macy entitled Dope Sick. For those of you who aren't familiar with this book, it is a deeply moving portrait of addiction in America. And it portrays the lives of young people who have been taken across Appalachia. One particular scene in this book that haunts me is when the author joins a woman, her name Christy Fernandez. And in the scene, Christy is at the grave of her 19-year-old son. And through her tears, Christy shares the memory of her son, Jesse, the high school football star, a burly, strong construction worker who had his whole life ahead of him. What tortures Christy even more than the grief of the loss of her son is the unanswered question: how could her boy who had never missed a day of work, how could he suddenly become a statistic? An individual found slumped over, lifeless, in someone else's bathroom floor. How could this happen? How could this happen? It's a heartbreaking question. It's a heartbreaking question that families across the country are grappling with every single day. In 2017, there were more than 70,000 overdose deaths, 68% of which involved opioids. The epidemic has contributed to a 3-year decline in American life expectancy, the longest successive decline since World War I. For every life lost, we know that dozens more are hanging in the balance. Today, roughly 2 million Americans are suffering from substance use disorder. And despite the scale of the crisis, treatment remains elusive. That's not for lack of effective tools. Medications like methadone, buprenorphine, and naltrexone have proven to prevent overdose deaths, and substantially increase the likelihood of long-term recovery. And yet, even more than 80% of the people struggling with substance use disorders, opioid use disorder, in America go without these treatments. Stigma is a formidable barrier in this case. Our country has ostracized, punished, and in some cases, even criminalized addiction. And that has led to people who know that they need help, led them to avoid asking for that help. Even when they do work up the courage to go and seek that medical care, there's no guarantee that that courage will be met with the appropriate response. Earlier this year, for example, researchers both at Harvard and at Johns Hopkins uncovered some of the reasons why, even when those who work up the courage to seek help don't get it. These investigators called hundreds of providers in states with high-burden opioid use, and they posed as uninsured and Medicaid patients looking for buprenorphine. What they found were substantial roadblocks to treatment. Here are some of the examples. They found that some doctors didn't want to take Medicaid patients. They found that others refused to guarantee that they would write prescriptions of buprenorphine at the appointments that they were able to finally get. And still other providers did not offer an appointment at all. Overall, there was an extreme reluctance to prescribe the medication, even though it has been proven to save lives, and even though every day that a patient goes without treatment, it is another day that they could die. This research speaks to what we know broadly about treatment access, that by far the biggest barrier are social and cultural barriers. The fact is, we cannot succeed in stemming the opioid crisis unless treatment is as accessible as opioids are. And that can't happen until we address the underlying stigma. The stigma that makes people who are suffering afraid to seek help. The stigma that makes providers hesitant to administer treatment. The stigma that keeps those in recovery from sharing their experience when it could help others. To start, we need to raise awareness about what opioid addiction and opioid misuse is. It is a chronic illness. It is a chronic illness that changes the brain chemistry and robs a person of free will. We also need to educate the public about what it is not. That means challenging the common misconception that addiction is a moral failing, or that addiction is a hopeless condition that befalls only those certain types of people. Because the truth is, opioid use disorder, while extremely dangerous, is treatable. We have many of the tools that we need to care for those who are suffering and to save countless of lives. And it's incumbent on us to come together and find better ways to do just that. And that's why today is so important. And that's why I'm so grateful that you're all chosen to spend your time here today. So I want to thank you again for being a part of this conversation, to talk in more depth and to bring evidence to today's program. I'm going to now turn over the program to Dr. Mary Bassett. Mary Bassett is the director of the Francois Xavier Bagnot, or FXB, Center for Health and Human Rights here at the Harvard T.H. Chan School of Public Health. Dr. Bassett is the FXB Professor of Practice of Health and Human Rights. She helped to craft Healing NYC, New York City's response to the overdose crisis, while serving as New York City's Health Commission. And I'm grateful that she's a member of our faculty and an architect of today's convening. Thank you, Mary.
Thank you, Dean Williams, for those truly moving and thoughtful remarks. And good morning, everyone. Thank you for joining us on what promises to be a very blustery day for the second summit on the opioid overdose epidemic. As you've heard, We have done this as a joint effort with the University of Michigan, and I'd like to acknowledge my counterpart at the University of Michigan, Dr. Chad Brummett. I'm scanning the audience, but I know he's here. He organized a terrific meeting in May with his team. I'd also like to note that it's fitting that today is World Mental Health Day. So I'm going to be your MC today, and let me just turn right away to some housekeeping issues. We have a very packed program. I'm going to try and keep all the introductions short. I'm sure all of you have gotten your program booklets and their full bios in that. We have a great list of speakers. You can turn to your program book to learn more about them. Please make sure that your phones are on silent. There will be coffee, tea, water available during the breaks, but keep in mind that only water is allowed back inside this room. And I also hope that you take advantage during the breaks to look at some of the artwork that's out in the lobby, some of which appears on the front of the program booklet. I want to thank Nancy Marks for allowing us to share this with you today. And last, if you're on social media, please use the hashtag OPSummit19. The goal of public health is to save lives, and it's a goal shared by everybody who's here today: clinicians, policymakers, law enforcement, advocates, activists, people, family, friends affected by problem drug use. And we have everybody from these spaces here, and we need everyone in order to tackle the overdose epidemic. Throughout the day, we're going to be hearing from voices of lived experience. I want to acknowledge that it takes courage to recover from substance use disorder, and it takes courage to talk about it. Massachusetts and Michigan have had a decline in fatal overdoses, as has the nation as a whole. But we still have so far to go. And as Dean Williams has outlined, we have the tools. We can overcome resource, policy, legal constraints. And you'll hear from many people today who've worked tirelessly to stem the tide that has already taken hundreds of thousands of lives. Looming on all of this is stigma and shame. The overdose epidemic is complicated. And like any epidemic, it tracks along the social fissures of our time. And one fissure that runs deeply through our nation's history is the legacy of enslavement of Africans. This is not our first opioid epidemic. I was a doctor in training at Harlem Hospital for the heroin epidemic of the 1970s and 80s, and that one affected mainly Black and brown communities where users were treated to handcuffs and not help. This history is important because it helped create the vulnerability to today's epidemic that began with a racially tinged presumption that people who deserved treatment for pain, who were insured and mostly white, would not become addicted to opioids. And doctors believed that Blacks were somehow addiction-prone and mistakenly assumed that whites were not if they had real pain. This racism, this implicit bias, also helps explain the stunning resistance to what we call harm reduction. So I have a whole list of organizations that I want to thank. I'll run through them really quickly because we're starting a little late. I want to thank the University of Michigan, the Michigan Opioid Prescribing Engagement Network with its SAMHSA State Opioid Response Grant, the Harvard University Office of the President, the Harvard Chan School of Public Health Office of the Dean, and my home at Harvard University, the Harvard FXB Center for Health and Human Rights. I also want to say thanks, without naming all of you, to the people who formed the advisory committee and lent indispensable insight during the planning process. Today is about people, not about stats and graphs. So I've asked Dr. Sarah Wakeman, who is an addiction specialist at Mass General, to kick off our symposium today with a conversation with Raina McMahon. If you could start making your way up. Dr. Wakeman met Raina McMahon first as a patient, and I want to thank you both for joining us today and turn it over to you. Thank you, everyone.
Great, thank you so much for having me, and thank you for that introduction. And I'm so glad that we're framing this conversation today first in the narrative of someone's lived experience, which I think too often is not a part of these symposiums or these panels. Well, there's been important and growing attention paid to the crisis of drug overdose deaths across the nation. There's been less focus on the healthcare needs and experience of people who use drugs and people with addiction. For every person who dies from a fatal overdose, many more come into our emergency rooms, our hospitals, and our healthcare settings. As we've seen deaths from overdose increase, there's also been an increase in infections related to injection drug use and for opioid, cocaine, stimulant, and alcohol-related health complications. When people who use drugs intersect with the healthcare system, too often they encounter stigma, unconscious bias, and outright discrimination. While people working in healthcare may have some awareness as to the potential harms of certain substances, I would guess that most of us don't think all that much about the very real harms of how we treat people who use drugs, how our systems treat people who use drugs, and how our institutional policies harm people who use drugs. This morning, we're here to explore how we can address the ongoing overdose crisis. And we'll start by focusing on the impact of stigma on access to treatment. To frame that discussion, I'm incredibly privileged to share the stage here with Raina, who is graciously willing to share her own story as a woman in long-term recovery, and also as a recovery coach who works with people who use drugs and people with addictions as they try to navigate the healthcare system. So I want to start, Raina, talking about this issue of stigma. So too often, stigma keeps people who use drugs and people with addiction out of the healthcare system and from accessing the care that they need. Can you share a little bit about your own experience when you encountered stigma in the healthcare system?
Yes, hi. So my name is Raina McMahon, and I've been in recovery for 6 years. And when I think about stories of stigma that happened to me during my active use, the stories that come to mind are the stories that really kept me from going back to get the care that I needed. So when I was in Boston, when I came to Boston, I had been using heroin for about 15 years, and mostly all the time I had brief periods of sobriety. And I started to get a lot of abscesses and infections, and I would go to the emergency room and I would be treated so poorly. And the nurses and doctors would basically say, well, this wouldn't happen to you if you weren't using heroin, and if you want help, here's a list of phone numbers, so go ahead and call these places. You don't have a phone, but go ahead and call. And I was so scared to get treated like that again that I started to lance my own abscesses, and I was volunteering at an animal shelter at the time. And I would steal cat and dog antibiotics and just take them myself instead of going to the emergency room to get treated like this. And you know, when a doctor or a nurse treats you in this way, it's already something that I felt about myself. I felt like I was a moral failure, that there was something wrong with me. And when I got treated like this, it just cemented the way that I felt about myself. So there was many false starts in me trying to get help. I would go to detoxes, methadone clinics. I tried to get on Suboxone, and the first time I tried to get on Suboxone, it was a primary care office in Revere, and it cost $500 to join this Suboxone clinic, which you can imagine when I'm using heroin every day, it was very hard to come up with $500. But I did because I was desperate for help, and a lot of people had said that Suboxone was going to help me. So I went and I met with this doctor, and he did the interview asking me how long I had been using heroin, how many treatment programs I had gone to. And when I told him I had gone to about 50 detoxes and was never able to get sober, he said to me, can you think about all the tax dollars it costs for you to go to detox, and here you are today? What is the matter with you? And I started crying hysterically. The nurse came in and said, listen, he's like this the first time, but just go get your Suboxone and come tomorrow. He's not going to be mean like this. I was so used to getting treated like this, I just expected it. And I'm like, this is what I am. I'm a horrible person. There's something wrong with me. But I was still desperate for help. So I came the next day. And when you start Suboxone, you have to be in withdrawal. And so he asked me, when was the last time you used? And I said, last night, right after I left your office, after you made me feel like a horrible person. I didn't say that, but I was thinking that. And he said, okay, let's start you on the Suboxone. Gave it to me, and I got sicker. He gave me another one. I got sicker. He had given it to me wrong because I wasn't in enough withdrawal, but I didn't know any better. So all day, I stayed in this office, and he kept giving me more Suboxone, and I was freezing, I was shaking, and I said to him, I said, can you bring me a blanket? I'm really cold. And he was like, yeah, I'll go get a blanket. And he brought me a blanket that was covered in vomit from every other person that had been in that office. I was so cold, I didn't care. I huddled under this blanket, covered in other people's vomit, just hoping that I would feel better. I didn't. He said, go home, keep taking the Suboxone. I didn't. I went home and I used. The next day I called and I said I wasn't able to, stick to this. I still felt horrible. And he said, you must be allergic to Suboxone. So all these years, I carried around this allergy to Suboxone. When in fact, I wasn't allergic to Suboxone. Didn't get my $500 back either. So that sent me back to using and basically hopeless because I felt like there was nothing out there that was going to help me.
Wow, I hear these stories. I've even heard most of Raina's stories, and it still makes me sick to hear the stuff that you've gone through and that many other people go through. I'm so sorry that you've had those experiences. As you've clearly highlighted, just in that brief time, I think compassion is often and has historically really been lacking in healthcare systems for people who use drugs and people with addiction. But there are moments when compassion has been found along that journey, and I've heard you share some of those as well. Would you be able to share with the audience sometimes where you actually did encounter compassion in the healthcare system and how that changed things for you as you move forward in your journey?
Yeah. So I think when you're so used to being treated subhuman, that if someone takes the 5 minutes extra to give you kind and compassionate treatment, it really means the world. And I think it was the second time I was hospitalized for endocarditis. There was a nurse there who would just spend a few extra minutes talking to me, and that night was going to be the last night that we spent together because I was going to be going to a medical facility after for IV antibiotics. And she came and she, little flashcards, right? How much does that cost? A few cents. And she wrote me these little notes. And I have carried these with me for 7 years. And this just extra belief in me, even though I relapsed after this, and I still carried these with me. So these little notes that she left me, I've got this. I spread love and light wherever I go. The universe has got my back. I close my eyes, clear my mind, breathe, and let go. And I am pure, positive energy. And many times when I felt like I couldn't do this, I would think of these sayings and I would just repeat them in my head. And just these few extra moments that she took just to give me some positive messages made me feel like there was somebody in the world that believed in me. And someone else, remembering my 1-year anniversary, my doctor, just a $2 card or a $5 card, I don't know. I'll give you a little more credit here. Just a little memento saying, I remember this is the day that you got sober 1 year ago, and just a note saying, I'm so incredibly proud of you. Something as small as that, you can see how meaningful this has been for me. I keep these in my bedroom. I see them every single day, and I'm able to look at this and say, there is somebody that believes in me, and I didn't have anybody, nobody, when I got sober. So just knowing that there was someone in the world that believed in me meant the world to me.
Thank you for sharing those. Those moments of kindness now in your work as a recovery coach, in some ways you get to share that and spread that belief in other people with the clients and the patients that you're caring for. Have you seen ways in which the healthcare system has gotten better or the care has gotten better as you work with people to navigate their own journeys to get their health taken care of or to access treatment and recovery?
So there's been a lot of great positive changes. I think there's a lot more work to go, a lot more changes to make, but the Bridge Clinic at MGH is something that's been extremely successful. I work at MGH Chelsea, which is an outpatient clinic, and when I'm working with someone that maybe isn't able to make appointments, they're able to go to the Bridge Clinic, which is treatment on demand. They can walk in at any time, get help with medication, treatment placement, and that has been enormous for some of the people that I work with.
That's great. Okay, I think we only have a couple minutes, so one final question for you. If you could wave a magic wand and help change the healthcare system to make it into a place that actually welcomes people in who use drugs or people with addiction, what do you think would be some of those important changes that would make a difference?
Well, I think one thing as far as the treatment system goes is I would bring back 30-day programs for people, because all too often I'm working with someone who goes into a detox, they finally decide that they want help, and they're not able to get placed into further treatment, and so then they come back to the same place that they were, on the streets if they don't have a place to live, and they start to feel hopeless, and then the blame often gets put back on them. So I've heard doctors and nurses and other people say, oh, well, they didn't want it bad enough. No, because when they did want it, there wasn't treatment there, and so they've given up. Like, why try if they're gonna go someplace for 7 days and not get placed in further treatment? No other disease, if you think about it, they don't start cancer treatment and say, oh, your next phase, if we have a slot, then maybe we'll send you there. But for addiction, it's not enough treatment.
Thanks, Raina. So you shared really the need for treatment on demand, particularly medication treatment on demand, like the Bridge Clinic, and then the ability to really access longer-term care services at whatever level people need. And throughout all of that, a little sprinkle of compassion and hope for the individual who's suffering.
Yes.
Thank you so much.
Thank you.
Thank you. Thank you, Dr. Wakeman. And are we now going to move on to our plenary speaker? Or are we going to take some? You're there. Okay. Thanks very much. I hope that you'll be around for a little today so that people in the audience can ask questions. I'm now pleased to introduce our keynote speaker this morning, Khalil Gibran Muhammad, who is a professor of history, race, and public policy at the Harvard Kennedy School, and the Suzanne Young Murray Professor at the Radcliffe Institute for Advanced Studies. Formerly, he was the director of the Schomburg Center for Research in Black Culture in New York City, which is where our paths first crossed. This is the world's leading library and archive of global Black history. He's the author of The Condemnation of Blackness and one of our nation's thought leaders on the subject of the broad intersections of race, democracy, inequality, and criminal justice. Thank you so much, Dr. Muhammad, for joining us this morning.
Good morning, everyone. And I want to thank Dr. Mary Bassett for inviting me to participate in this important conference, and to Dean Williams for hosting us within the context of the Chan School of Public Health. Just a disclaimer, so I am a historian and not a medical professional or clinical scientist. And so my interests in this field turn really on some deeply embedded ideas that I think have to be front and center in this work of solving the crisis as it is with us, but to anticipate the ones that are yet to come. And I think that is the challenge of our moment. So let me open with setting a scene. Philip Montgomery wrote an essay in the New Yorker called The American Opioid Crisis a couple of years ago. Mostly it was a photo essay, and in that photo essay he drew our attention to the death and suffering of those who had passed in the wake of their own opioid addiction, but also to the communities they left behind. He was able to document these scenes by taking ride-alongs with police officers and describing this area of Dayton, Ohio as a very normal suburban street. Everyone had a story to tell about personal addiction or knowing someone who had died from an overdose. What's important to know about heroin, he wrote, is that it completely eliminates pain, physical pain and emotional pain. And in some ways, that is a very striking reminder of the pain at the center of this epidemic, but oftentimes we miss the social pain. And that's a lot of what concerns me with regard to how we think about history in relationship to this present. In Montgomery County, Ohio, where Dayton is, the coroner had literally been running out of room to store the dead bodies. The morgue was at capacity, and the county at the time had the highest overdose rate per capita in the country. He added that all the officers I rode with knew everybody by first name, knew their parents, knew their siblings. And in this way, he said, as a journalist, this was something he didn't expect. He didn't expect the proximity of law enforcement and their own relationship to this community to be so close. And as such, he wrote, if you're speaking to a deputy police officer, they all have their own theories about how to explain this. On one hand, they attribute it to multiple generations of heroin users in one family. And in others, they say it had a lot to do with doctors prescribing opioid pain meds. So thinking of that frame just a couple of years ago, let's go back about a half century, about a very different time of a different opioid crisis. In 1970, President Richard Nixon described drug use as, quote, America's public enemy number one, demanding an all-out offensive against it. He had a clear vision of drugs and crime as two sides of the same evil menace. If we cannot destroy the drug menace in America, then it will surely destroy us. Nothing less than total war would do. His own advisor, many years later, admitted in an interview, some of which has become famous and very familiar to many of you, but for others, perhaps you're hearing this for the first time. John Ehrlichman, who was a special advisor to Nixon, described many years later in an interview that the Nixon campaign in 1968 had two enemies, the anti-war left and black people. You understand what I'm saying? We knew we couldn't make it illegal to be either against the war or against black people, but by getting the public to associate the hippies with marijuana and blacks with heroin, then criminalizing both heavily, we could disrupt those communities. We could arrest their leaders, raid their homes, break up their meetings, and vilify them night after night in the evening news. Did we know we were lying about the drugs? Of course we did. And indeed, heroin was an epidemic crisis. In some ways, as Eric Schneiderman has described, a literally city-killing drug in the early 1970s. The American city, as a result, appeared to be on its way to its own morgue. Abandoned and burned out buildings, which addicts had converted into places to sell and shoot heroin, scarred many urban neighborhoods, scarred many urban neighborhoods. Urban residents worried about burglaries and muggings as crime rates soared. In New York City, addicts stole an estimated $1.5 billion each year, and street crime threatened to make life there untenable. The majority of heroin users were thought to be African American and Latino. Indeed, according to federal authorities, approximately half the nation's heroin addicts lived in New York City, in areas comprised mostly of African Americans and Puerto Ricans, who comprised about 3/4 of the city's users. A tidal wave of heroin addiction had swept through the inner city in the late 1960s, and those users engaged in an inordinate amount of street crime, Schneiderman wrote, that threatened the life of the city. And so, what did African Americans themselves make of this moment? What emerged to some degree was a punitive response even within the black community. After all, heroin users had indeed become public enemy number one in the nation and even in Harlem. For this, heroin addicts were described as having burglarized barbershops and beauty salons, stole typewriters from job training centers, robbed banks and churchgoers. Speaking of crime victims everywhere, just to capture the language of the moment, a man named Lou Borders, whose clothing store had been broken into 12 times, said, "That Soul Brother stuff, you can forget about it." The Black Weekly New York Age agreed, quote, "clean out the scum and put them away as long as the law will allow." Echoing such sentiments, a columnist for another Black newspaper was unsparing. "I'm in favor of burning them alive." Thousands of people, for those living through this moment in our community, are afraid to go to work in the morning and they're afraid to go home at night. But this was, even in the 1970s, an old story. Researchers had long been looking at opioid abuse since World War I. Much of the research revolved around an expanding federal apparatus under the aegis of the new Bureau of Narcotics, founded in 1914 with the Harrison Act. And yet, in that founding moment, like so much else in American society, race helped pour the foundation of our medical, scientific, and political understanding of drug use. As the historian Donna Murch puts it, historically, the fundamental division between, quote, dope and medicine was the race and class of the users. The same year that the Harrison Act passed, a physician named Edward Huntington Williams announced in the New York Times that year, 1914, in a headline, "Negro cocaine fiends are a new Southern menace. Murder and insanity increasing among lower-class blacks because they have taken to sniffing since deprived of whiskey by Prohibition." This was not the Prohibition, the federal Prohibition that was to come within a few years. Drug use was linked explicitly with violent crime and monstrous strength. He wrote, "often incites homicidal attacks upon innocent and unsuspecting victims, bullets fired into vital parts that would drop a sane man," which is code for white, "in his tracks. Fail to check the fiend, authorities can't stop it." And note the subtle use of the object it, a thing, not a human being. Black poverty equaled Black pathology, of which drug addiction was but a natural and normal condition of an inferior race. The Black body itself stood as a visible symbol of America's racial hierarchy. The stigma attached to it has always been, that is, the it of the Black body, has always been the work of social systems in this country designed to maintain white supremacy. What those systems have done from media to education to academia to healthcare and so on is to stigmatize Blackness as a form of currency for valuing white lives. The hierarchy is white over Black, but shades of social status and meaning are inflected by groups deemed non-white or immigrant or poor or among other social markers of non-normative status. So let's take a broader view of this, particularly through the prism of criminal justice, which has a huge footprint in our current opioid crisis. In the progressive era, neither white crime nor violence, in fact, justified harsh punishment or discrimination when dealing with European immigrants. To the contrary, liberal researchers at the time called for less policing and more pro-social interventions. They themselves were responding to the punitive ethos of the eugenicists and the social Darwinists of that era. They rejected the language of personal responsibility or moral character. They rejected a focus on chastity or morality. They described struggling whites and immigrants as a great army of unfortunates, driven to madness, crime, or suicide by an unfair economic system. It's the struggle of the masses against the classes, wrote one of the foremost demographers and public health experts of the period, a man named Frederick Hoffman. These compassionate white researchers and reformers redefined white crime, drug use, and violence as symptoms of class oppression, and they built on-ramps to higher-paying jobs and exit ramps out of poverty. Gang-affiliated, drug-involved, criminally active whites in America's fast-growing inner-city slums of that period certainly heightened public safety concerns. In 1903, here in Boston, a researcher found that the Irish had the highest rates of petty crime, and the Italians topped the list for major felonies. Chicago's Jane Addams, the most influential and social worker and community activist of the early 20th century, witnessed white-on-white violence daily. She wrote a study trying to make sense of 15,000 youth brought before Chicago's juvenile court in 1904, 5 years after that court opened in 1899 as the first alternative to incarceration. It was a perfect expression of a public good intended for deserving juvenile delinquents. As she described, those young people stole from their parents, swiped junk, pawned their clothes and shoes, did any desperate thing to get dope, as they called it. After describing the grisly details of a gang-related shooting where a Polish youth shot the brains out of an Irish boy, Addams wrote, "This tale could be duplicated almost every morning. What might be merely a boyish scrap is turned into a tragedy because some boy has a revolver." Another white teenager from a little farm in Ohio added, had shot and killed a policeman while resisting arrest. Stories after stories and scenes after scenes of an epidemic like this one, for liberals, turned into a cause célèbre to help immigrants and poor whites by building a new and improved social and economic infrastructure to support them. New housing, new labor laws, new jobs, new criminal justice policies. By contrast, racist depictions of Chinese immigrant opioid use in California in the late 19th century and Mexican marijuana smugglers in the Southwest for decades were subject to violent vigilante and state reprisals, as well as public policies of control, containment, and quarantine. You might ask, what happened about Prohibition, or what happened then? Of course, during Prohibition, I would argue, was the last gasp of a punitive response of a conservative element in American society to pursue retributive justice for those even then caught up in alcohol, bootlegging, or consumption. Southern and Eastern Europeans bore the brunt of the stigma, and yet the progressive campaigns of a slightly earlier period had helped to redefine them as white people on the path to assimilation. As one leading criminologist of the time period wrote, the second-generation immigrant appears to approach the native-born of native parentage in regard to the crimes committed, and as such led to a fundamentally rewiring of the nation's infrastructure in an effort then to move away from prohibition to a more compassionate social welfare system known as the New Deal. And so, while Asian immigrants, Southern blacks, and Mexicans bore the cultural and political burdens of the stigma of natural drug users and criminals, the majority of drug users in America have always been white. Demographically speaking, this is unsurprising. And yet, the way racial stigma works is to sort addiction categorically by the moral character and constitutional fitness of the user's ascribed racial group. So let me bring my remarks to a close. The historian Matthew Lassiter is working on a book called The Suburban Crisis. He's a University of Michigan historian and one of the leading scholars of metropolitan history and looking at the way that race and space have been sorted as resources for various kinds of participation in our economy and social fabric. For him, the very idea of a criminal white drug user is what he calls an impossible category. He argues that the political category and cultural symbol of the young white middle-class victim has been central to the ebb and flow of the war on drugs and the urban dope pusher, the foreign trafficker, and the predatory ghetto addict. Policy formation has consistently operated within a consensus framework where politicians seek to protect white middle-class communities from crime and drugs and to impose law and order programs in their inner cities and on the border. One translation of this is, as he notes, going back to Richard Nixon's policies in the early period, is that the decriminalization of marijuana use and possession, and the heightened felony criminalization of heroin use was essentially an argument for throw the book at the trafficker, but don't lock up my kid. An impossible public policy, the criminalization of the social practices and consumer choices of tens of millions of white middle-class Americans categorized in both politics and cultures as, quote, otherwise law-abiding citizens. That is, white drug users as too big to jail. So here we are today, and we see the impact of our federal policies playing out right before our eyes. Shortly before the results of the 2016 election, Chris Christie noted, addiction is an illness and is something we can beat. If we're giving people the tools and support they need to overcome this disease, if we choose to free people from the stigma of addiction and recognize this as a public health challenge, it truly is, we can help to reclaim their lives. We can find the true measure of our compassion. The investment we're making will change lives and get more people into treatment earlier instead of the emergency room or prison later. It's exactly what we'd want to hear. And yet Chris Christie himself was a former Attorney General in the midst of the wars on drugs that are responsible for America having the largest prison population the world has ever known. Just a year before Christie's address, James Comey, while still director of the FBI, in response to Black Lives Matter, had this to say, that the greatest challenge in that moment is to grow, as he wrote, drug-resistant and violent-resistant kids. And then finally, our White House officials, most recently in the midst of this opioid crisis, have announced $1 billion of spending on treating those already addicted. We are delivering life-saving help. And as such, Trump announced in a White House speech in 2018, quote, tremendous amounts of money and care have been given to special facilities for heroin users. People are hiring these inmates, Trump noted. They're getting a second and sometimes a third chance. But of course, by contrast, candidate Trump had evoked the language of the war on drugs on the campaign trail. Quote, we have to bring back law and order in a place like Chicago, he said, citing crime rates as evidence of African American and Hispanics, quote, living in hell because it's so dangerous. He frequently described such places as scenes of carnage. It is too easy to lament that we made a mistake with how Black people were treated in the 20th century drug wars. That now public health researchers know better. But that would presume that our criminal justice and public health systems have been broken all along, and now we just need to fix them. I can see why some would believe this, but these systems were not broken. They were built this way. And contrary to what might make us collectively feel better about the morally bankrupt, racist double standards that have defined the long history of our nation, we should not deceive ourselves that the system was supposed to produce different outcomes. Because racial stigma has functioned as a signal for deservingness, for resources, as my Radcliffe colleague Liz Chiarello explained to me, rehabilitation, treatment, even the state's use of surveillance over violence are all forms of public goods that have been rationed based on who is white and who is not, who is deserving of them and who isn't. And so the challenge for us as we move through this opioid crisis and deploy the tools that are with us is to ensure that we break that historical cycle. Thank you.
Thank you, Dr. Muhammad. I just want to note how important these remarks are, and I hope everybody takes some time to digest them while we assemble the first panel of the day. In New York City in 2017, African Americans outnumbered the number of fatal overdoses compared to any other group, and other cities are seeing these racial crossovers. We all must be vigilant about how the atmosphere may change as we see a change in demographics. remembering this history. But now we're on to a very important topic of the day. I'm going to turn it over to Dr. Shelley Greenfield, who is the moderator of the first panel of the day. She is the professor of psychiatry at Harvard Medical School, the Christine Trustee. These names are all so long. And she's a really important person, chief academic officer at McLean's, and she will introduce the panel.
Thank you so much, Dr. Bassett. I am really pleased to be here today with all of you for Harvard University and the University of Michigan's second joint summit on the opioid crisis, with today's summit focusing specifically on this critical issue of stigma and access to treatment. I know all of us have already, just even in this brief time we've already spent, and for the rest of the day, we will learn a lot from one another as we seek answers to how we might overcome stigma and discrimination in treating and preventing opioid use disorders. It's really universally acknowledged in the field of opioid treatment that stigma is a critical barrier in access to care throughout and at every level of the healthcare system and more broadly in our society. I think Raina McMahon's description of her experiences, which I found very painful to hear, bring home to all of us the human consequences of suffering and how this affects people who are our family members, our friends, our neighbors, people in our communities. And so I'm really honored to have the opportunity to moderate this panel entitled Stigma and Access to Treatment, and to introduce you in a moment to our very distinguished for our panel. I want for a moment to just provide you with a few details about how we're going to structure our panel today. We want to leave ample time for robust discussion with each of our speakers. So what we're going to do is have each speaker present for about 8 minutes. I'm then going to moderate a panel discussion with the three speakers for about 30 minutes or so, and we'll have about 5 to 10 minutes to take questions from the audience. So in keeping with this planned format, in a moment, we'll first hear from Dr. Sarah Wakeman, the medical director of the Massachusetts General Hospital Substance Use Disorder Initiative and assistant professor of medicine at Harvard Medical School. She will talk about stigma and access to treatment, the role of language and ideology. We'll then hear from Dr. Jeffrey Samet, the John Noble Professor in General Internal Medicine and Professor of Community Health Science at Boston University School of Medicine and Public Health. He is the recipient of one of 4 historic, very large Healing Communities grants from NIH, the National Institute on Drug Abuse, and he's going to speak on stigma and access to treatment, a healing community study perspective. And then we will hear from Dr. Pooja Lagasetti, the assistant professor in the Division of General Internal Medicine at the University of Michigan, and also the Center for Clinical Management and Research at the Ann Arbor VA. She's going to speak on another critical issue, a really emerging and critical issue about chronic opioid use, stigma, and treatment access. So with that, please welcome our first speaker, that's Dr. Sarah Wakeman.
Great, thank you so much. Let's see here. Perfect. Okay, first, that's a tough act to follow. Thank you so much for that amazing talk, which covered so many important issues, and I hope everyone was listening in particular that the system, in fact, was designed to do exactly what it's been doing. So I think it's no accident that people are treated in a punitive fashion, particularly Black and Latino and Latina individuals. So today I'm going to talk briefly in my 8 minutes, I talk fast, so that's good, about the role of language and ideology as we think about stigma and access to treatment. Do folks know who this individual is? Dr. Dole? Hands in the audience? No, I see a lot of blank faces. Dr. Dole was the physician scientist who discovered methadone as a treatment for opioid use disorder. He was actually an endocrinologist by training and really came to understand severe opioid use disorder as being similar to other endocrine problems like adrenal insufficiency or insulin-dependent diabetes, where for some people with the severe form of the illness, they really need a daily medication to allow them to feel normal and function normally. And he published these amazing papers in JAMA in 1965 that were the earliest studies we had about medication
medication treatment for opioid use disorder. And this was an interview with him as he reflected on his career, sort of stumbling into the field of addiction medicine, and reflecting on the fact that he came to it with all the same biases that most of us, I would argue, hold, being members of society and raised in the U.S., around who is a person who uses drugs, who are those people, and thinking of people who use drugs as being weak and untrustworthy and deceitful and bad, and really coming to understand through his work with people that this is entirely false. And yet that distortion, those stereotypes, that discrimination has intentionally influence our policy and the way we think about people who use drugs, the way we take care of people who use drugs, and the systems we've built and the drug policy we've developed to deal with those issues. And so as we think about access to treatment, we really have to understand it within that backdrop, that we've spent 100 years as a country, for a lot of reasons based in racism, as we heard, designing a system that really punishes people who use drugs as people who are bad and doing something bad. And so undoing that is not a small task. And yet we've actually had huge advances in the science of addiction and treatment. This is an article published in the New England Journal of Medicine by Dr. Volkow from NIDA, which needs to change its name. I'm going to talk about the language later, but the National Institute of Drug Abuse, and Francis Collins, the head of the NIH. And they reflect on the fact that if we think about any public health crisis, it's been science that's really allowed us to get our arms around the crisis and effectively impact mortality and public health outcomes. And when we think about the ongoing overdose crisis, it will be no different. And thankfully, we again have 50, 60 years of really good evidence on what it is that works, what reduces mortality, what treatments are effective. And in particular, when we think about the overdose crisis, we know that medication treatment saves lives. We've heard that mentioned a little bit. We heard Raina's terrible experience trying to access medication treatment. And unlike other public health crises, when we think about the HIV epidemic, where we had to wait for science to catch up, we had to wait for new breakthroughs and medications that were going to be effective, we have medications that reduce the death toll by at least 50%, if not more. The slide there on the left is France's experience, where they allowed broad access to buprenorphine in the midst of their heroin epidemic and saw an 80% decline in heroin overdose rates. And yet the graph on the right is from a paper I wrote with my colleague Michael Barnett, who's in the audience here, looking at the growth in prescriptions of buprenorphine. And in the midst of this crisis, we are not seeing a massive response of access to life-saving medication. And there's huge disparity in who does have access to medication treatments. And many of those barriers are based in stigma, discrimination, and ideology. So why does care for addiction look so different? So I would argue that the beliefs, the ideology at the core of how we think about people who use drugs are the true barrier that we have to address. Yes, we need systems of care, we need broader access to medications, we need Medicaid expansion, we need many things, but at its core, until we get over this notion that people who use drugs are doing something bad, and that yes, maybe they have an illness, but they also are bad people, or they're sinning, and this is a bad behavior issue, and therefore we need to punish them into just knocking it off and pulling themselves up by their bootstraps and getting better. That until we get rid of that core notion, our treatment systems, the way we approach these individuals will never look different. And so undoing that is going to be at the core of really revolutionizing our care system. And I would argue that a simple but incredibly impactful thing that we could all do is change the language we use. So much of the terminology that we use when we talk about people who use drugs or people with addiction looks nothing like the language we use when we talk about other public health issues or health conditions. So we talk about substance abuse. You saw my sort of notation about the terminology that NIDA uses. There's no other health condition where we use the term abuse, which literally means a willful act of misconduct. We don't describe people with eating disorders as being food abusers or people with diabetes as being sugar abusers. And so with our very language, we're sending the message to these individuals that we're talking about building systems of care to take better care of, that they're to blame for their condition. Similarly, calling people addicts. We don't talk about the breast cancer or the schizophrenic. We've learned that really using person-first language that identifies the human who is experiencing the illness rather than describing them simply by their disease is crucial. So I would argue there are terms that we simply should never use in our medical lexicon, including addict, abuse, abuser, junkie, clean or dirty. Even the term clean, which is used in a positive light, really implies that people are struggling with active illness or dirty. So an individual I know who's a recovery coach was interviewing for jobs, and he said on the interview trail, people would say to him, "So how long have you been clean for?" And his response was, "Well, I've been bathing since I was born, so I've been clean my entire life, and I've been in recovery for 5 years," or whatever it is. And then I think there's a lot of confusing terminology. So the term medication-assisted treatment. What is the medication assisting? We don't talk about insulin-assisted treatment or Prozac-assisted treatment. We just talk about treatment. Why do we use this different language when we're talking about addiction? And then the difference between dependence and addiction, which hopefully we'll get into with Pooja's talks, because this really penalizes people who experience chronic pain and benefit from opioid therapy. And there are many other terms that you'll see listed there that I think are incredibly problematic. In addition to the language, changing the narrative is crucial. There's been a wonderful effort that I've been a part of that's been a coalition of people who use drugs, people in recovery, people with chronic pain, scientists, policy experts, lawyers. We've all come together to try to think about how can we begin to change the narrative around people who use drugs in the midst of the overdose crisis. And we have a website with common tropes that are repeated throughout the narrative around overdose crisis. But I think one thing we don't talk enough about is the need for hope. Much of what gets portrayed in the literature, in the public press, is what my colleague Zach describes as opioid disaster porn. It's all of the terrible stories, and it's not the messages of hope of the people who get better, the 24 million people in this country living in long-term recovery. And then the racial disparities in the way we continue to criminalize black and brown individuals who use drugs while talking about white individuals as being sick is incredibly problematic, and we heard a little bit about that. And then lastly, I just want to share a message of hope myself, that change is possible even in big, bureaucratic, slow-moving healthcare systems with doctors and nurses that, as you heard from Raina, have historically been steeped in stigma. Practice can change, attitudes can change, and one thing that creates that change is access to treatment. I would say that many people go into healthcare because they want to help, and when they feel like they have no tools and they don't know how to help, it's very tempting to blame the person who's suffering, and I think we see that with people with addiction all the time. This is just some data from Mass General of doctors before and after we rolled out an initiative to increase access to treatment across our care system. And we found that doctors who had a patient get care from that initiative had less stigmatizing attitudes towards caring for people who use drugs, less stigmatizing attitudes toward medication treatment, and they were actually more likely themselves to offer treatment, to prescribe medication for opioid use disorder, to give people in the naloxone who are at risk of overdose. And so that change can happen, and making tools and effective care available is one component of getting there. So with that, I'm going to use up my whole 8 minutes. Thank you very much.
Good morning. Thank you all for being here. I'm going to speak to you today about stigma and opioid addiction from a very pragmatic perspective. And in order to show you why it's so pragmatic, I'm going to spend a little bit of time just telling you what is the pragmatic issue. So the Healing Community Study is a federally funded study, NIDA, SAMHSA, that involves 4 states where we're trying to decrease opioid overdose deaths by 40%. So a few minutes about the study. And this is really a clinical trial. So the terminology is there: multi-site, parallel arm, a cluster randomized comparison trial across 4 states. The participants in this are communities. So we actually have 67 communities that are involved. The goal, as we said, is to decrease opioid deaths. Our specific goals here are our specific approach is to increase availability to naloxone, okay, an overdose agent for people who with opioid use, to enhance the delivery of medication for opioid use disorder. We've heard a lot about that today. Key for decreasing opioid overdose deaths, getting people in recovery on medications prevents deaths. Identifying and engaging high-risk populations. You know, if you looked at the number of people who overdose and die, half of those people have touched the medical system, but half have not. So how do you get to people? How do you get the message to people? And then improve prescription opioid safety. If you look at these 3 main approaches, stigma is central to the top 3. So stigma, if we're to be successful in this very large study, we have to think about just what we're spending the day talking about here, addressing stigma. And basically, this is to show you the communities, if you're from Massachusetts, the communities that we're talking about within our state here. And then I'm just going to take the rest of the time for a few minutes thinking about what do we mean? How are we going to go about this? And I actually, to prepare for this talk, I gathered the team members and I said, so we're making a lot of plans now to go into these communities and to take on this issue. What do you guys prioritize as the main things we can do to get through the stigma, beyond the stigma, deal directly with the stigma to make a difference? And this is the list we came up with. Celebrate recovery. So what do I mean by celebrate recovery? If you're celebrating something, then it's a topic worthy of achievement. And it's a source of pride. It's not the source of shame, as we've heard so eloquently by Ms. McMahon, our individual with the lived experience today, speak about it. So celebrating recovery, how do you go about implementing that? Well, from a clinician's perspective, I'm a primary care doc, you let a patient know, congratulations. You know, if you're in the office and how long you've been in recovery now? 2 weeks, 2 years, 20 years? Just appreciate the fact that that takes work. From a family perspective, efforts to educate families who have taken on a great burden of family members' challenges dealing with addiction, but for family members to celebrate their affected family person, be it a child or a parent or a sibling, would also be a step towards celebrating recovery. And then individuals need to feel, as we heard today, proud about their recovery as well and be able to speak about that. Some can, some cannot, but to appreciate either privately or publicly that. Communication becomes a big deal, but specifically communications around medication for opioid use disorder and the use of medications to reverse opioids, such as naloxone. And as we heard today, stories are powerful. And telling those powerful stories, as we've heard today, about good stories, bad stories, the combination of both, that can change people's perception of stigma. Stigma versus discrimination came up. Someone said, you know what, is it stigma or is it discrimination? And in certain settings, you can just say, we're talking discrimination. We're mislabeling it if we're calling it stigma. When we have patients on our inpatient medicine service who we go to discharge to facilities who say, well, we don't take them because they're on methadone or they're on buprenorphine. That's not stigma. That's just pure discrimination, and we need to call it for what it is. Criminalization, and some people say is the ultimate stigmatization. I think we heard plenty about that from Dr. Muhammad, and I won't even speak to that anymore. But I would say that there's hopes that within the criminal justice system that there's helps to lowering stigma that's possible. In some ways, drug courts can begin down that path, and then other efforts, creative efforts like PARI, for the people who know the police addiction recovery initiative, where they have people can go to police stations when they're using and withdrawing to seek treatment. That's turning the table. That's a sort of novel piece. And then finally, which is really the heart of this study that I introduced you to in the beginning, is engaging communities. The hypothesis really, one major hypothesis in this study is that communities are different. And the answer that one community might pursue is going to be different, or the method to the answer may be different than another community. And so dealing with communities and getting down with them to say, what is it are our needs? Maybe our needs are criminal justice, maybe they're not. Maybe they're school-based, maybe they're not. Maybe we need a bridge clinic in our emergency department, et cetera. Understanding those communities, we think, will be key. So with that, thank you for your attention.
All Great, thank you so much. Today we've heard from Dr. Wakeman and Dr. Samet about stigma and access to treatment for patients with opioid use disorder. But I'm going to add to this conversation about talking about how stigma, and perhaps we should call it discrimination, is affecting patients with chronic pain. So, how widespread is this problem? Over the past several years, there have been multiple policies and guidelines that have been aimed to restrict inappropriate opioid prescribing. However, recently there's been concern that perhaps we've gone too far. We've seen several media headlines highlighting this issue for patients taking opioids for pain. This one says, limits on opioid prescribing leave patients with chronic pain vulnerable. Montana's pain refugees leave state to get prescribed opioids. The pain refugees, the forgotten victims of America's opioid crisis. An opioid crackdown forces pain patients to taper off drugs they say they need. As a primary care physician, I was also seeing this in my own clinic, where patients had gone from doctor to doctor just trying to find a physician that was willing to care for them. And I couldn't help but wonder, how big is this problem? Are these just jarring headlines and anecdotes that are making the news, or is this a really big problem? So we decided to quantify treatment access. And we did this by conducting a secret shopper study across a sample of Michigan primary care clinics to see if they would be willing to accept and potentially prescribe opioids to a patient who may need chronic opioid therapy for pain. I want to acknowledge that one of the med students that helped us today, Claire Garbstadt's here today too. Prior studies have shown that primary care access is affected by insurance type. So we decided to randomize our clinic calls by insurance status. So half, as you'll see, were a patient with Blue Cross Blue Shield, and the other half was a patient population that said that they had Medicaid. In this study, the RA called the clinics to see if they would schedule an appointment for their elderly mother who happened to be on opioids for a long-term back injury. The RAs would first ask if the clinic was accepting patients, and if they said yes, they would reveal the mother's insurance, and then say, before we get too far, is it okay if my mother takes opioids for pain? We were surprised. I expected this to be a problem, but not this big of a problem. 41% of the primary care clinics were not willing to see and potentially schedule an appointment for this patient. And we found no difference by insurance status. So why are they closing their doors? We also asked our RAs to capture exactly what they were saying to them during these phone calls, and there were some interesting responses. A lot of clinics cited administrative burdens, just too much work, out of control with the new laws. With the state cracking down on prescribing of these kinds of medications, they, being the physicians, just don't deal with this stuff anymore. We also heard about fear of sanctions and liability. New laws, they're really flogging down on doctors, and they could potentially lose their license if they keep prescribing a lot. It's not the doctor, it's the laws and policies. But I couldn't help but wonder, what was the role of stigma here? I was on a plane sitting next to a primary care physician, and I asked her if her clinic had any such policy, and she actually said, of course, you have to screen for whether they're doctor shopping, and we do this by getting prior records. And so I knew there had to have been a role for stigma. So we dug deeper, and this time we called clinics in 9 states, and we varied these states based on how high their overdose rates were. We called 452 clinics 2 times, using 2 different scenarios. In both scenarios, there was a patient that has been taking Percocet for years. But this time, in scenario 1, the reason for needing a new primary care physician was that their doctor had retired, the previous doctor had retired. In scenario 2, which could be construed perhaps as slightly less benign, we said, my doctor just stopped prescribing it for me. So what happened? In 452 clinics, called twice, 75% of the clinics responded the same to both scenarios. So 32% said yes to both scenarios. They were willing to at least see the patient for the first appointment and then decide whether they would prescribe opioids. And 43% said no to both scenarios. So this was similar to the ratio that the percentage we got in Michigan alone. But interestingly, 25% of our clinics responded differently to each scenario. Now, if you thought that this was completely random and stigma was not playing a role or impacting decision-making, we would expect there to be an equal distribution of clinics who said yes in either scenario. However, we found something really different. 65% of the clinics were more willing to see and potentially prescribe in the scenario where the physician had retired. This meant that the odds of being seen if your doc retired was almost 2-fold greater than if you didn't provide a reason. So Stigma was certainly playing a role. We captured quotes again. If you're just looking for a prescription, he won't do that at all, but he can help you with a natural approach. You might have to go to mental health. Keep in mind, this is a scheduler, and this is a patient with pain. This doctor treats addiction, and since Percocet is addictive, it would negate his mission. And this was one of my favorites. He is a kind of Catholic doctor and feels that he is doing a bad deed by prescribing that stuff, so he doesn't prescribe. So going back to the language of sin that Sarah had brought up. So how do we solve this access issue? And you certainly need a multifaceted approach. And I'm not saying that statewide laws, insurance policies, clinic-level factors, and you can imagine a small clinic in rural America may act differently than a larger community health center somewhere else. But I want to remind you that in our study, we held these factors constant. We called the exact same clinic 2 times. So the same clinic had the same laws, insurance policies, clinic-level factors. And in 25% of those clinics, there was a different answer. And so we cannot ignore the fact that there is provider and staff stigma for patients with chronic pain. Thank you.
So, can you hear me? Yes. Okay, great. So thank you so much for 3 excellent talks. I appreciate all of the comments that each of you made, and I am looking forward now to having a conversation amongst all of us. And so if I could just start with a question to Dr. Wakeman. You were highlighting in your talk the role that stigma can play in the access to medication treatment for opioid use disorder. And I'm wondering if you could elaborate on that, how the stigma limits access, but also if you have some thoughts about how we can begin to address that.
Yeah, I think this is a huge issue, and although there are many barriers to access to effective medications for opioid use disorder, I would argue that stigma and discrimination are probably the biggest barriers. I think first there's misunderstanding, and often stigma can be rooted in misunderstanding, but people have a challenging time getting over this idea of using a drug to treat drug addiction, and there's a lot of common myths out there that you're just replacing one addiction with another. And I think one challenge is that much of the healthcare system, including doctors and nurses, are not necessarily educated about this. It's not a part of medical school training. A minority of doctors ever get specialized training to be able to prescribe medication for opioid use disorder. And so there's no sort of counterbalance within the healthcare system of people who are educated about the role of medication treatments. And so that myth has persisted, and even many healthcare providers in the survey data that I showed you believe that treatment with methadone or buprenorphine, they said on a survey, was just replacing one addiction with another. So I think that notion is one of the more pernicious ones. I think our language perpetuates that. So I mentioned the term medication-assisted treatment, which is a term that's favored here in the United States. And that really sends this message that medication is assisting some other magical component of treatment, despite the fact that the treatment with the most evidence behind it for opioid use disorder is medication. And that's in contrast to organizations like the World Health Organization, which termed its guidelines psychosocially assisted pharmacotherapy. So really the notion that medication is a cornerstone and that psychosocial assistance is important, but is assisting that. And then lastly, I think the way our systems of care, both within the healthcare system and then within the criminal justice system and the treatment system, have outright discrimination towards people on medication has perpetuated this. So nursing facilities, despite the fact that they're now being sued under the American with Disabilities Act, are not accepting patients who are on methadone or buprenorphine. Treatment facilities within the addiction world don't accept, many of them don't offer and often will not accept people on medication treatment. And then within the criminal justice system, despite many randomized clinical trials showing mortality benefit and cost savings and decreased recidivism, the vast majority of facilities don't offer medication treatment for opioid use disorder, with the exception of the state of Rhode Island and now some pilot facilities across Massachusetts and some outliers like Rikers Island across the country that have been doing this for a long time. So we're beginning to see the tide shift, and yet that stigma, that misinformation, and that outright discrimination continues to serve as a barrier.
Thank you. And so it does seem, though, that there are some evidence-based models that are dotting the country that we could consider whether or not there are opportunities for us to adopt those in a more widespread way. And we are beginning to see those, if I'm understanding what you're saying correctly.
Yeah, absolutely.
So I'm wondering if we build on some of the opportunities we might have to learn more from lessons in the past. I know, Dr. Samet, one thing that you've talked about, you didn't have a chance to comment on in your presentation, is that there are lessons you believe that we can actually learn from efforts that we had to decrease stigma amongst HIV positive patients, and what we may have learned in that epidemic that you believe could be applied to this current public health crisis that we have.
Sure. You know, for those of us that were practicing medicine or came of age practicing medicine during the HIV epidemic, there are parallels. Not identical, but there are parallels. And one strong parallel is the fact that here were patients that were ill that were not coming into care. And a big part of their reason of not coming into care, especially in the early 90s, was the stigma that had been associated with this new plague that was hitting the country, hitting the world. And you know, as we reflect back on it, in 2019, not that stigma has been eliminated with HIV, but I would argue it has been greatly reduced, especially in this country, still being worked on internationally. One big issue is that it transformed into a treatable illness. And the fact that it was treatable, there was even more reason to come in. There were success stories. We said how important stories were. There were success stories of people saying, especially when the medications became particularly effective. And there seems to be analogous issues there where, as you've heard from people thus far, medications for opioid use disorder are highly effective. People die at a remarkably reduced rate from overdose if they're on medications. That's a message that's out there a bit, but the fact that opioid use disorder is a very treatable illness would be a nice lesson learned from the HIV. One other little piece there, I would say that, and someone commented on this to me lately, and it does come up, is that key to the HIV epidemic making progress were the activist groups that were around, ACT UP being a common one. And we haven't seen to date, to the extent that one might expect us to see, that type of activism. There's some, but it's at a lower intensity level, and that's potent too. It gets things moving, but an element of it definitely reduces stigma.
So thank you for the comment, and also it ties back, I think, in the major studies that you are leading and others across the country in healing communities, in assisting communities in combating stigma will partly be encouraging advocacy and activism within communities to demand treatment for people in the communities at all levels. So I think it does tie back to this large study that you and others are doing across the country, which will be incredibly important. I think, Dr. Lagasetti, you have touched on another part of this crisis that we aren't really paying as much attention to, and I think is actually something that patients and clinicians across the country are experiencing in a widespread way. And I'm wondering if you could talk to us a little bit more about how we can approach solutions to combating the stigma that you just discussed, that you saw in individual clinics. Like, what can we actually do to help people understand the difference between people who have chronic pain, use opioids, use them as prescribed, use them effectively, have used them for years, and do not have an opioid use disorder? What can we do to help?
I personally think that language plays a big role. I think the terminology is very confusing to a lot of people, dependence versus addiction, and what does this all mean? But I think the one thing that my study, really brought out to me is that I think we're addressing a lot of this, or we're trying to address a lot of this on the prescriber level, on the physician, MPPA level. And keep in mind that when we were calling these clinics, this was a staff person. This is a person answering the telephone. And in my own clinic, I will say that the same person answering the telephone is the same person running my prescription drug monitoring program checks, fielding opioid refill calls, and taking on a lot of what has become the administrative burden to offload me as a prescriber. And so I think it really highlighted to me just how we can't just focus on one prescriber or one problem. We have to be thinking about the culture as a whole and the clinic as a whole when we're devising solutions, because it can't just be the physicians that we're talking to. We have to be thinking about everybody that's being impacted by these new regulations as well.
Can I just push that a minute further? Like if you were going into a clinic and you wanted to assist, what would you actually do?
Yeah, I had some patients that have asked this question because they've said, well, one of the media responses to the first study that I presented was, well, maybe the patient would just never reveal that they are using an opioid, and then that's how they could get in the door, right? But then you can't help but think, like, how many doors does this patient need to get into before they actually find an appropriate physician? And is this just like a waste of the healthcare system to be going from door to door trying to like hide your opioid use until that first visit? And so, I do think that this is definitely a challenge. I don't know if there's a role for the physician calling it, the patient calling it out for what it is, which is likely discrimination, and asking, further. We definitely had RAs kind of get, like the phone was, hung up on them, different things were happening. We didn't capture all of this in here, but this is a big problem.
So with that in mind, Dr. Wakeman, what are some of the key components that you would see as an effective approach to these systematic barriers that we've been discussing to improve lives and health of people who have substance use disorders, opioid use disorders, and who are using drugs in ways that are harmful to themselves and to others?
Yeah, so when I think sort of systematically about how we begin to address the overdose crisis, and although this is an opioid summit, I intentionally am using the word overdose crisis because we're really in the fourth wave now, where we're seeing rising deaths due to stimulant and cocaine use, in addition to ongoing deaths due to a poison drug supply from illicitly manufactured fentanyl. So I really think in kind of three buckets. The first is prevention, which is arguably the hardest. The second is treatment, and then the third is harm reduction. I think we have to be thinking about all three of them. So from a prevention standpoint, I think the focus on prescribing opioids probably belongs in that bucket. I think, unfortunately, policy-wise and within the healthcare system, most of the attention is focused on prescribing, which both harms people with chronic pain, but also harms people who, in fact, have an opioid use disorder, who then get pushed into the illicit drug supply, which, again, is poisoned and increases their risk of dying from an overdose. So I think prescribing responsibly and thoughtfully definitely has an important prevention role, but it has to be a measured response. And the much harder work of prevention is really addressing adverse childhood experiences, early childhood trauma, community-level factors that make an individual at risk for developing a substance use disorder in the first place. We know genetics is about half of the equation. We can't do anything about that. But the other half of the equation, the sort of contributing environmental and exposure factors, we absolutely can address. And that is outside the purview of what we think of as medical care, but really does belong in the bucket of public health and how we think about long-term prevention. Within the treatment, I think we've heard that stigma is a huge thing. People don't come into care when they get treated terribly, as we heard from Raina and as we heard with the analogy of HIV. So reducing stigma, making care easy to access so that it really is available when people come into any healthcare setting. If someone's coming to the hospital, the emergency room, their OB doctor, their ID doctor, their primary care doctor, they should be able to access treatment immediately. This shouldn't be a tough thing to access. And medication treatment has to be a component of that, given the evidence showing reductions in overdose death and improved rates of recovery. So expanding access. And then I think we can't talk about treatment without talking about harm reduction. Harm reduction has to be a part of how we think about treatment. It's a part of how we think about every other aspect of medical care. We don't only focus on sort of the perfect treatment outcome. We focus on reducing the negative consequences of ongoing illness. And so making sure we're thinking about broad access to naloxone, overdose education, safer use practices, safer injection practices, syringe service programs, and supervised consumption sites as all proven interventions to reduce the ongoing risk of dying from an overdose in the midst of ensuring we expand access to treatment and focus on prevention.
Yeah. Thank you. Yeah. One of the things, Dr. Samet, that we heard, we've been hearing this morning is that there's been a tremendous stigma impact of the criminalization focus on illicit use, and we heard an amazing talk earlier about just all the historic roots through the 20th century by Dr. Muhammad. I just wondered if you had comments on the stigma impact of criminalization and what you think we need to do to move forward from that?
I won't take any more time talking about the negative impact of criminalization on stigma and opioid use, but perhaps reflect a little bit on things we might do moving forward. And Dr. Wakeman's comments on thinking about prevention, treatment, and harm reduction, it's interesting to think about those things within the criminal justice system. In truth, there's not a lot of stigma around the prevention piece, but not that a lot of it happens in the criminal justice system, but there's the treatment and the harm reduction. There's a lot that can be done there. I mean, when you think about, I've actually always thought that the criminal justice system, and particularly the incarceration dimension of it, gave huge opportunity, given the disproportionate number of individuals who are in the criminal justice system who have these disorders. And probably it's stigma that gets in our way of getting treatment to be part of the system. We heard that it's in some selected places now. Hopefully that's the beginning of a wave. We'll see, but it's going to take stigma reduction to basically, I would again say, celebrate the successes, because I think Rhode Island, there have been successes, and Rikers shows that it can happen long term with outcomes that are positive. The whole harm reduction in criminal justice systems is sort of the nouveau area to explore. But I'd put it on the table because, you know, nothing saves lives with opioid use disorder to the extent, and nothing's been demonstrated to save lives to the extent that naloxone, the overdose agent, has shown to be. So something along those lines with, upon leaving prison for people who, incarceration for people who are at risk, what an opportunity. And if not for those individuals, for their family members or friends that they will go back and have social interactions with. So I'll leave it there, but addressing the stigma to those type of things happening would be a step forward.
So one of the things, I think, tying together some of the things we've heard about earlier today and some of the comments you've made, I think we have a lot of disruptions as people transition from any part of the system to the next part of the system, where there's no way to ensure that people actually have some rational, smooth path from one part of the system to the next, so that if they are in fact being treated within, let's say, the prison system, what happens when they're released, and will they be able to sustain that treatment? If they're on treatment before they enter a criminal justice setting, how are they going to sustain their treatment while they're incarcerated and then beyond? That is reflected in every aspect of our healthcare system. Ms. McMahon talked a little bit about the fact that she wished there were 30-day programs that used to exist because people don't get access, even when they're treated for 4 or 5 days, to systems that actually will be rationalized and make sense. So I think there's so many parts of the system that are so non-integrated and disrupted, and I think it is yet another theme. And one thing I was wondering, Dr. Legacetti, in the area that you are working in, do you have a sense that reimbursement policies play a part in encouraging physicians or systems of care to care for the population, for example, that you're working with?
Yeah, I mean, I think when you think about a population that has chronic pain, so our first study basically showed that in the primary care practices, it didn't matter whether our patient had Medicaid versus Blue Cross Blue Shield. But we've also been conducting studies looking at, whether there's pain specialists around and whether, perhaps there would be comprehensive pain management in a specialty setting as compared to the primary care setting. And, not surprisingly, we called almost 400 clinics in the pain setting and found that, almost all of them offered procedures. Only, I think, about 30% offered PT. 13% had behavioral therapy, and 25% actually offered CBD products. So more CBD than behavioral therapy. And in that setting, only half of these clinics would take on a patient who had Medicaid for health insurance, and almost all of them wanted a primary care referral, which I just showed you that half of our patients can't get a primary care referral. So, I do think reimbursement practices are filtering down. And so if we're thinking about pain management as a whole, if our specialists and the way we have thought about pain traditionally has been procedural or, quick shops, then we have to be thinking about how reimbursement patterns can be changed so that we can offer more patient-centered care that may take a longer appointment and may not involve a procedure. And so these things, may not filter into the primary care setting until they filter into the specialty setting first.
Thank you. That may be a huge possible opportunity and policy lever that is actually really available to be pressed big time right now across all the states and federal policy. So I think it's an important one. One of the things we've been also talking about are communities and families, the way that they're affected by opioid use disorders, and as you point out, other substance use disorders that co-occur. You talked about the actually emerging crisis in methamphetamine and stimulants as another wave combined with the current crisis that we have. And I'm just wondering if you have thoughts about how family members can play a role in supporting their loved ones with opioid and other substance use disorders addressing these access barriers. Like, what can family members do?
Yeah. Well, first, there's so much that family members can do. I think probably the first step a family member can take is really learning about what is a science-based approach to caring for someone with addiction. There's a great sort of article written for the lay press entitled "What Science Says to Do If Your Loved One Has Opioid Addiction," which I often recommend to family members, and it really goes through very basically a lot of what we've talked about here, that medication is life-saving, a lot of the common myths around people who use drugs and people with addiction, which I think is a huge area that we can help families to really undo some of the harmful myths. And what I mean there is the myth of tough love or enabling or letting people hit bottom. Those are probably the three most common myths I find families really wrestle with, where they feel terribly guilty, like they're harming their loved one by just loving them and being compassionate. And they often do things that can be harmful to the person because they feel like they're supposed to. They were told that you have to practice tough love and you have to kick your loved one out. And I think that gets at one of the harmful myths around people who use drugs and people with addiction, and again, our policies towards people, that if you think about the definition of addiction, which is defined as compulsively using a substance despite negative consequences, despite bad things happening to you, how will having more bad things happen to that person help that person get well? And yet, what do we do as a society? We take people's kids away, we take their jobs away, we put them in cages, we kick them out of our healthcare system, we tell their families to kick them out on the street. And yet we know that using drugs is an incredibly powerful coping mechanism during times of stress. So we're making someone's life worse at the exact time when they need support, they need love, they need compassion, as we heard about from Raina. So I think really supporting families in that, and then really helping them to understand what evidence-based treatment is, and particularly around the role of medications, because I often find that inadvertently patients who do start on medication treatment, if their family members and loved ones know, they sometimes get pressure to come off of medication because of this misunderstanding about, oh, you're just replacing one drug with another. And so inadvertently, and sometimes subtly and sometimes not so subtly, family members or support systems can actually harm an individual by encouraging them to stop the very medication that's keeping them well, which again is not something we do if our loved one was on insulin or if our loved one was on HIV medications or tamoxifen for breast cancer. So I think really enabling family members to enable health, to enable someone to stay alive, and flipping that concept on its head, that we all want to be enablers, but we want to be enabling people to stay healthy, to stay alive, to engage in treatment, and to be well.
And I would also say, to your point about the myth around hitting bottom for people, there's no other medical condition that we aren't trying to actually intervene at the earliest possible moment, because we know intervening at the earliest possible moment actually assists people in getting better quicker, faster, staying well, staying healthy. And so it is so much of a harmful myth shared by the public, patients, families, as you point out. And so it sounds like you're educating for family members to become as educated as they possibly can about what to do, what treatments work, and to begin to communicate that to their loved one is one way that they can assist somebody in their family. And to also understand, to a point that you made, I think, Dr. Samet, that there are people who are in recovery and do well. So the more that people can understand how people recover and actually do well and actually feel well over the long term, that also provides a lot of hope, I think, for families and families banding together in those ways. Just to turn the topic to something a little bit different in terms of stigma, and we haven't really talked very much about this, Dr. Samet, but I'm wondering if you can talk about the impact on stigma of the association that we have of homelessness with those who use opioids. And we haven't really spoken about that.
So homelessness and addiction are related. They're both stigmatized. They're different. And maybe just to appreciate the interactions, and then you can kind of appreciate the stigma. But I think I would make the case that if you're homeless, and we see this with our patients, it's really hard to put first things first. If that's one of the AA lines of just deal with what you have to deal with. Well, when you don't have a place to sleep at night, that kind of becomes the first things first. So your drinking or your opioid use is not going to be top of the order. So these issues are related. When I think homelessness is important. I mean, so much so that when we put this Healing Community Studies together, we decided it was worth investing in an individual with expertise in homelessness to make that an issue that is also addressable. In fact, we're fortunate in Massachusetts, there are housing opportunities that exist. They're not easy, but they exist, but getting to them is actually tricky. So having expertise to help you get there. So we sort of feel like, look, if treating addiction is the goal to preventing overdose and saving lives, then we need help addressing the homelessness. Part of that is getting around the whole stigma of homelessness itself, but to recognize that they interact for some people, probably a minority, but an important group, and it might be a particularly challenging group to treat, and then give it attention.
Thank you. Dr. Legacetti, in your work, as many primary care offices say that they're unable to take on the management of chronic pain patients, and we are encouraging non-opioid therapies for pain. What do you think about patients finding better treatment, do you think, or more comprehensive care through a pain management office? Like what role do pain management services play in helping patients who have chronic pain at this point, do you think?
I briefly alluded to this before, but we've called almost 400 pain management clinics in these exact same 9 states, and very few of them are offering what we consider to be comprehensive pain management or multimodal pain management. A large proportion of them, exclusively do procedures, and then, as you kind of filter down, they're doing what we consider much more brief interventions. And they're not exactly well equipped to provide what may take more time, possibly because of reimbursement processes for things like behavioral therapies that have been shown to work, or physical therapy, or other modalities. And so, one, I think the common argument is that these pain specialty clinics only exist in certain communities, well-resourced communities. And then on top of it, if you take the places that they do actually exist, and if they don't even offer the adequate services, then it's hard to turn to them. And I will say that when we called these primary care clinics, that was often a response. They would say, you should go to a pain specialist. That's not me, And so, I think that the way we're talking about this, when we're saying like that's the solution, unless we can, somehow, administer kind of quality standards for these pain specialists and or, make sure that this treatment is affordable and accessible for all, I'm not sure that we can go ahead and start to say, as primary care physicians, this isn't my business, this is the specialist problem.
Dr. Wakeman, when you were talking about addressing stigma, you've also talked about some of the myths that are out there. I know you've commented on some of them. Are there other myths that you think are really important that you haven't commented on, that you think sort of are some of the drivers of some of the stigma that we see, both in terms of patients and self-stigma, but also what we see amongst providers and also the community at large?
Yeah,
Yeah, I mean, there's so many common myths and or sort of tropes about addiction and about drug use. I think probably first, you'll notice I often use both the language people who use drugs and people with addiction, just as a reminder that most people who use drugs never develop addiction. I think there's this notion that they're one and the same, but drug use does not equal addiction. And in some ways, the interesting question is, why don't we all have addiction? 90% of us are exposed to highly addictive substances, and most of us will never develop a substance use disorder. So I think that's an important distinction. Even with drugs like heroin, like cocaine, where often the image is that sort of one use and you're hooked, or that you develop addiction. I think the other is that this myth that people who use drugs don't care about themselves, that they don't care about their health, that they don't care about their community. I think that couldn't be more untrue. I think because of the way we punish and criminalize drug use, people who use drugs have had to look out for each other and themselves in a way that's incredibly remarkable. The survival instinct and the way that people take care of their communities and people that they love that are dying, as we all sort of watch from the sidelines, I think is really remarkable. And there's growing activism, and there are growing unions of people who use drugs, but that again has been not a large part of the narrative, in part because of the stigma and the way we criminalize people. But I think just to emphasize that, why do we have naloxone? Why do we have syringe access? Why do we have a lot of these life-saving interventions? Because people risk their lives and risk going to jail and to prison to fight for those things. And often those are people who themselves use drugs, or because people that they loved use drugs. And so I think that's a really important myth to undo, particularly in the healthcare system, where people like Raina experience this representation as if because you use drugs, you couldn't possibly care about your health because you just did this to yourself. And I think that is so very harmful and so very untrue.
Can I just ask any of the three of you, or all of the three of you, one other thing that's a theme that we haven't made explicit, and I'd like to make it explicit, which is that we often don't really talk as fully as we need to, I believe, about mental health when we're talking about people with opioid and other substance use disorders. In fact, across all three of your talks, we are really talking about many people. You mentioned the ACEs, we were talking about communities, we're talking about people with chronic pain, and we know that there's this high co-occurrence of people with psychiatric disorders, or what we sometimes think of as mental health conditions. We also call it mental illnesses, and the reason we have so many names for that is because that's yet another highly stigmatized area of our public discourse. And so I sometimes think about these patients who have double and triple whammies, basically, in terms of the stigmatized nature of what the problems are. I would ask each of my colleagues here if you would, it's the world I live in, and I have a great concern about is how we actually take care of people when they are really combating all those stigmas simultaneously, and what do we do about that? So go ahead.
I'll make a first volley at it from a different angle than you probably intend. But, and it speaks a little bit to what Dr. Wakeman was just talking about with myths. And that is that one myth is that patients are challenging and difficult to take care of. In truth, especially when you use the armamentarium of medications, incredibly satisfying patients that, despite being challenging, make you feel like, as a physician, like you're doing really good stuff and you're using your skills appropriately, so that you have complicated patients, yes, they're often young, who do well, who turn their lives around, and then you see them over time. So the myth is that they're not satisfying. They're incredibly satisfying. Remember perspective. If you're working in the emergency department all the time and you're always seeing them at their worst moment, it can be difficult to keep that in mind. If you're in the outpatient setting, it's in your face all the time in a real positive way.
I would say that the co-occurrence of psychiatric illness really argues for the need for integration in all parts of the healthcare system, that just like we find primary care doctors who won't take care of patients with chronic pain or won't provide opioid use disorder treatment, sometimes our patients with substance use disorder can't access psychiatric care because there's been this fracturing of really the medical system, the mental health system, and the addiction system as if they're three separate things. And yet our patients experience these as all intertwined. They don't think of their problems as, oh, well, this is my mental health problem, this is my addiction problem, and this is my medical problem.
problem. And we need care that recognizes those realities and really undoes the stigma that has led to these siloed models and really delivers whatever care people need in the moment that they need it, wherever they show up. And I think that argues for integration across the system.
Yeah, I couldn't agree more. I think that, especially when you think about patients with chronic pain versus patients who may have an opioid use disorder who are all on opioid therapy, you'll often hear stigma even amongst the language from your patient population. So you'll have a patient with chronic pain come in and say, I'm not that person, I'm not the addict, I'm not this. And so we're all kind of siloing ourselves into these buckets. And if we keep thinking about pain separate from addiction, and then addiction separate from mental health, and not building systems that can address all of these in concert together, I think that we're always going to be kind of building these like stigmatized factions as we keep moving along.
Well, and I will just go back to the comment that you made earlier about reimbursement, and I will just go back to a policy lever that actually exists to encourage the kinds of integration that you're talking about, because that's often also a tremendous barrier for patients to access the care that they need across all those different service sectors, as you just said. So, at this point, we could open this to audience questions. I believe that what we had planned to do was we have 2 microphones on either side, and if audience members have questions for... Oh, I've just been told that we have time for 2 questions. So if I could maybe start over here. And if you could just identify yourself, your name and anything else, if a place of work, if that's relevant.
Sure. I'm Liz Chiarello. I'm a professor at St. Louis University in sociology, and I'm a Radcliffe Fellow at Harvard this year. Thank you for a fantastic panel. This was absolutely very interesting and very relevant. The question that I have is about this emerging theme that I'm seeing about the relationship between resources and stigma. And we have kind of a chicken and the egg question. Do we need to change hearts and minds in order to get the resources that we need? Or do we need to change the resources in order to change hearts and minds? And I was really compelled by one of the studies you showed, Dr. Wakeman, about providing resources to a clinic and then being able to see that they thought about their patients differently. And so is your thought that if we flood the system with resources, that people would start to think differently? Or do we really have to be changing hearts and minds in order to get the resources necessary?
Well, I'll start, and then I'd love to hear Dr. Samet's perspective, too. I'm going to reflect on my own mentor, Dr. Rich, who's a doc down in Rhode Island who works in the correctional system, and he talks about spending 2+ decades trying to change the hearts and minds of the correctional system about care for people with addiction, and he was still waiting at the end of that 20 years despite spending millions of NIH's dollars on randomized controlled trials and proving that different models of care worked. And then the thing that changed things was the swipe of a governor's pen and millions of dollars poured into the system to say we're doing this and we're doing it now. So I think sometimes waiting for people's hearts and minds to change takes a lot longer than we have in the midst of a crisis where 6 people will die here in Massachusetts today. So I think, yes, we want to fight stigma by education and story and narrative and all of these important pieces. And yet it's a tall order to ask people to feel differently who feel like they're on the front lines if they have no tools in the toolbox and no resources to turn to and really no way to help people who are dying. So I think without resources, we will never address stigma.
I don't really have much to add. I think the answer is both, and I think Sarah said it eloquently.
Thank you.
Good morning. Good morning. My name's Christian Thrasher, and I'm with the Clinton Foundation. And thank you very much for the panel. Stigma is something that I think about on a daily basis as someone in long-term recovery myself. More of a comment than anything, but it's something that really I've been thinking about as I've been listening to all of you share. And that is, when I listened to you talk about medication-assisted treatment, it reminded me that for many, many years, the only aftercare, the only follow-up that we recommended for people that went through treatment was get into a 12-step fellowship program. That's it. And that model is based on stigma. I'm Chris Thrasher. I'm a person in long-term recovery, and I use my last name because anonymous is stigmatizing. For so long, when I was using drugs, They didn't say Chris T in the paper. They said Chris Thrasher was arrested for this, that, or the other thing. And then I get in recovery and I don't use my last name. And it doesn't make any sense. You know, so the very model of an anonymous fellowship is based on stigma. Now, back in the 50s and the 60s, it was illegal for two addicts to be in the same room together, so I get why it started. But we need to change a culture. That's what I'm hearing from all of you. We need to change a culture, and it's going to take many, many years, but it starts by saying, this is my name, first and last, and I'm proud of the person that I am, but I am stigmatized. You know, I worked for the former Surgeon General for 15 years, and it took me 5 years to tell him that I was in long-term recovery, and I had 12 years in recovery when I started to work for him. I brought him to his first 12-step meeting. He gave me my 20 and my 25-year coin, and so it's a big deal for me to be able to stand up and say, I'm not anonymous anymore. What we know is employment, education, housing, and human connection can make a difference, and all of you, I think, shared very, very well about that. And I just really appreciate this opportunity to say I'm not anonymous anymore. So thanks.
I actually can't imagine a better comment to end this panel on. I just cannot imagine. I really want to thank you for coming to the microphone and sharing the story. I think it fits beautifully with what we're trying to say, that these are the recovery stories that are long-term that need to be celebrated and make a huge difference in the discourse and the things that we need to be talking about much, much more for the sake of everybody in our community. So I really thank you. I also want to thank all of the panelists for these wonderful presentations and also for sharing all of your wisdom with the rest of us. And with that, thanks for all of your attention.
Thank you. Thank you, Dr. Greenfield. And thanks for everybody who's joined us so far this morning. You are now going to have a 10-minute break. I would ask you please to come back in on schedule so that we don't get behind in the rest of the program. Thank you very much, and thank you to all of our speakers again.